If we could go ahead and close that door to minimize distractions, that would be wonderful. I think we'll be able to finish this chapter today. You're already working on heart dissections this week, so hopefully we'll be able to get into the heart chapter to discuss a few things, at least briefly, before you get into lab. We are on the area of the outline formed elements, so we're talking about cells and platelets. So erythrocytes, leukocytes, and platelets, or thrombocytes are actually another term for platelets. Erythrocytes is Latin for red cell, and these are indeed our red blood cells, also abbreviated RBCs. That's my favorite abbreviation for them. We have a different descriptor for our RBCs than we do our lens. Remember our descriptor for our lens? It was biconvex. How would you therefore describe the RBC then? Biconcave. Perfect. So we have a biconcave disc here. And it has no nucleus. And that's pretty obvious when you take a look at them underneath the microscope. No nucleus, pretty much red. And actually it looks like they almost have a hole in the center, doesn't it, on sometimes? Because that's where the nucleus used to live. So the nucleus lived in that center area. And before the red blood cell left the bone marrow, the nucleus is actually extruded. It's kicked on out. So these cells originally did have a nucleus, but before they enter the circulation, the nucleus is removed so that they improve their oxygen carrying capacity. So the nucleus is removed before they are emitted into the bloodstream. This is about approximately 44% of blood volume. And one of the descriptors for RBCs, or red blood cells, is that they are just a bag of hemoglobin. And hemoglobin is abbreviated HB. We have two nice pictures here. One superior view showing we're looking down on it. And typically on a smear, this center area is very pale. It's not dark like we see in this view here. And then this is just where they have actually sliced through it to show you its biconcave nature. They're easy to recognize because blood is everywhere, correct? Always inside a blood vessel though. Blood is everywhere, but it's still always inside a blood vessel because blood vessels supply vascularity to our tissues. And so it's easy to recognize this as a blood vessel here. We have a bunch of red blood cells stacked up in this area, and quite honestly, that is a capillary. This is obviously a very, very high magnification, but this is a capillary because it only has one single layer of endothelium or simple squamous epithelium around that. And so here is another capillary. And so it shows you how red blood cells actually can kind of stack up as they go through capillaries. And capillaries only have to be as big as or slightly larger than the width of a red blood cell, which is actually pretty small. I don't use 75, I use actually 8 micrometers in my descriptor of the size of a red blood cell. So if you have a red blood cell around in an environment, you can actually use it. If you remember, memorize 8 micrometers or microns. Let's go ahead and say 8. You can use that to actually figure out the size of something close by. So you can use it as a pseudo measuring stick. Let's take a look here at our list of functions. Hemoglobin. So it's a bag of hemoglobin, and hemoglobin is designed to transport oxygen. Let's say carry first, and therefore transport oxygen. When we take a look at hemoglobin, it has 4 hemes. That's where it gets hemo from these hemes and globin from the protein component, so hemoglobin. Heme is this molecule right here that in the center has iron. So heme of hemoglobin is what has the iron component to it. And then globin is indeed a globular protein. Remember we talked about functional or fibrous proteins and then functional globular proteins. So fibrous proteins are structural proteins, globular proteins are functional proteins. And do you guys remember primary, secondary, tertiary, and quaternary structures of proteins? What do you think this globin is? It's a quaternary structure. So we have several polypeptide chains that are all kind of hooked together, and that's hemoglobin. Now, it's interesting, we have at least 250, I can put plus, million hemoglobin molecules, M for million, per RBC. So 250 plus million hemoglobin molecules per RBC. What's important is each hemoglobin can carry 4 O2 molecules. So 1 per heme. So 1 oxygen molecule per heme, and there's 4 of them. So we have greater than 1 billion oxygen molecules per RBC. So that's an important feature of our red blood cells. They're a bag of hemoglobin and they're designed to carry oxygen. And they take it to wherever oxygen is needed. And that's an important stuff. The other thing that's interesting or important about hemoglobin, it can carry CO2, carbon dioxide. But carbon dioxide does not attach to the hemoglobin in the same area that oxygen does. So oxygen is definitely associated with the heme portion of hemoglobin, but carbon dioxide is not. So the carrying area for carbon dioxide on the hemoglobin molecule is a totally different site. Why or what stimulates us to make red blood cells and therefore the hemoglobin molecules, which are basically what a red blood cell is all about? The process is called again, that Latin for red, erythropoiesis, which means to form, generate. So erythropoiesis is the formation of red blood cells, and it occurs in the red marrow of our bones. Do you guys remember where the red marrow is located in an adult? It's in the diploe of flat bones. So our skull bones, our sternum, our ribs, and even portions of our ileum. So, and where else? There's two other important areas. See, we don't have a lot of areas where we get red blood cell formation anymore. Head of the humerus and femur. So those are the only areas that we actually have erythropoiesis occurring. So erythropoiesis, the formation of our red blood cells. What's absolutely fascinating, the stimulus to actually make more red blood cells in our red marrow is a hormonal mechanism. And we did talk about this in our endocrine chapter, but the organ that creates this hormone is our kidney or kidneys. So our kidneys actually create this hormone called erythropoietin. Isn't that interesting? Erythropoietin causes erythropoiesis, or the formation of brand new red blood cells. And so the kidneys are definitely hooked into our circulatory system. And they are kind of monitoring if we are getting enough oxygen to our tissues, in essence. Because that's the stimulus. The stimulus for the release of erythropoietin is if we are not getting satisfactory oxygenation to our tissues. So let's take a look and see if these reasons here actually meet up with that. Erythropoietin release is due to decreasing RBC numbers. Well, yeah. If you don't have enough red blood cells, you don't have enough oxygen being delivered to your tissues. Good. Decreasing oxygen availability, such as when we actually become Sherpas. Right? Because the higher we go on a mountain, what do we know about oxygen? The less oxygen content to our air. So therefore we upregulate, correct? We make more things that will actually grab onto oxygen, which is our hemoglobin, and therefore hemoglobin's always inside our red blood cells. So that's decreased oxygen availability, and then increased tissue demand for oxygen. So what would be a reason to have, what would fit in that category, a descriptor? Marathoning, right? You're becoming a marathoner, right? Because marathoners go for long periods of time and with their activity, and they need extra oxygen to help them maintain that and keep their ATP level up. What about if you're really sick, like the general adaptation syndrome, where you have sepsis and you have pneumonia or meningitis? Remember, you're going to have everything hyped up, so you're going to actually have an increased need for oxygen. So erythropoietin would also be released. Erythropoietin is manufactured synthetically and has a name. It's called EPO. And erythropoietin is actually a drug of abuse. Do you know what group of people likes to abuse EPO? No, it's true. Yeah. Your high-paid athletes would like to have EPO, right? Because the more EPO they take, the more red blood cells they make, the more oxygen they carry, and the better their endurance, correct? So the Olympics are coming up. And, you know, they do a lot of drug testing for them. They're not testing them for opioids, people. They're actually testing them for enhancers of performance.
I think they're testing Russia first.
Well, they need to test Russia 3 times. And don't believe each report. So, yeah. So EPO is actually a synthetic medication or drug that's abused, actually, by people. What do we need to make red blood cells? Besides erythropoietin, we need the usual in our diet. So we need, because it's a protein, you know, we need to have adequate protein intake for amino acids and stuff, and we need to have, additionally in our diet, we need iron in our diet. We need folate, which is a B vitamin. And then in addition to that B vitamin, we need another vitamin called vitamin B12, cyanocobalamin is the name for vitamin B12, but it's easier to say B12 than cyanocobalamin. So vitamin B12, folate, or iron. These all are necessary for normal DNA synthesis of the precursor cell. The precursor cell, remember, has a nucleus. And so that's why it says necessary for DNA synthesis in the precursor cell. What happens if we have a deficiency in any single one of these? What will result if we have a deficiency in either iron, or a deficiency in folate, or a deficiency in vitamin B12? Anemia. Anemia is the result of a deficiency of any single one of these. So who's at risk for iron deficiency? Third world countries, because where do we get iron in our diet? Proteins, specifically nice meat. That's right. We typically get iron from meat, correct? Because part of meat's a blood vessel. And so we actually ingest in our meat products iron from their red blood cells, and also part of the myoglobin and things along that line that are actually part of our meat products. So iron deficiency also occurs in women. Why? They menstruate. They have regular blood loss. And also, what if they are a strict vegan? So even in the United States, we can have easy iron deficiency anemia. Folate is also a vitamin that's in lots of foods. So folate deficiency is harder to do unless you're on some sort of starvation diet. But vitamin B12 deficiency is very common in the elderly because part of B12 absorption requires you have normal acid production from your gut. And if you don't have normal acid production from your gut, you will not get normal vitamin B12 absorption from your diet. Do we know of anybody in our country that doesn't have normal acid production in their gut besides the elderly? There's people that take a lot of medications over the counter that stops acid production in their stomach. Right? You guys know what I'm talking about? Antacids, which kind? For GERD, gastroesophageal reflux disease? Yeah. So how about Prilosec? How about Protonix? How about Prevacid? Have you guys ever heard of any of these things? These stop normal acid production. If you stop normal acid production, you will stop the production of a very important component that's required for B12 absorption. So even people that are actually taking long-term medications for various conditions are at risk for other problems because of that. In other words, do you understand there's no perfect solution for any one problem? Well, but the human being, so keep that in mind. Fate and destruction of red blood cells. They have a 120-day lifespan. So after 120 days, are you dead? Oh, why are you still here? After 120 days. Are all of them produced only once and then 120 days later? No, we have this continuous production of red blood cells, right? So when 10 die today, 10 will die tomorrow and 10 will die tomorrow, but then 10 will be produced today and 10 tomorrow and so on and so forth. So 120-day lifespan. What happens is these cells are broken up. They are like a flat tire. And they are phagocytized, taken up by phagocytes in the spleen and the liver. The reason they are broken down is because they have no ability to repair themselves. Because what is important for a repair process in a cell? The nucleus. So they are anucleated, which means no nucleus. So they no longer have the instructions or information to help them fix any breaks or tears in their surface. And they are bouncing along in your bloodstream all the time. So as you bounce along in the bloodstream against the vessel walls, you end up kind of getting roughed up, so to speak. And so 120 days later, they're roughed up as rough as they can get, and then we take them out of the circulation because once they pop, what leaves them? Hemoglobin. So that's popped. They're no longer useful, and so let's take them out of the system. And we do with the spleen and the liver. The various components of the red blood cells are disassembled, and if there's anything we can recycle, we do, and we do so in the liver. So we don't actually throw away everything. We actually take what we can, reuse it. Unless you're actually heme. And we cannot recycle heme ourselves. And so we will actually put there's a part of heme we can't recycle, and we put that part that we cannot recycle into our bile and excrete it in the form of bilirubin. So heme becomes bilirubin, and that is what is in our bile, and that's part of what gives our bile its color. So this is all done by the liver, the formation of bilirubin from heme. Now let's...
In jaundice, is our bilirubin high or not?
In jaundice, your bilirubin level is high. But your bilirubin level should be handled by the liver, right?
Right.
And liver should be putting it into bile, which is part of what's in your gallbladder, right? And then Bile is actually excreted into your digestive tract and pooped out. Part of what gives your stool its lovely color. Okay. If you're jaundiced, then that means that it's not getting into the export system and it's getting into your bloodstream. And that is something that typically happens with a certain itis. Actually, more commonly, hepatitis. Hepatitis, hepatic is liver. So hepatitis is inflammation of the liver. And with hepatitis A, hepatitis B, hepatitis C, for example, a very common symptom of that is jaundice. Now, newborns, the reason newborns have jaundice issues is because they have a lot of immature systems. And the immature system that they have when they're born is an immature liver. And so the liver is not yet capable of putting it into the proper proper waste management system, and so you end up with jaundice for those kids. But that's easily fixed because we can treat it with sunlight, because the skin helps break down. Sunlight in the skin will actually help break down bilirubin for us. But that's another story. Leukocytes, WBCs. Leuko is white sites, white cells. There's less than 1% of our total blood volume that are actually our leukocytes, and you guys, I hope, realize these are very important fighters of infection, so they're part of our immune system. All of our WBCs or leukocytes possess a nucleus. They are also produced in the bone marrow, and there's an and here, not just the bone marrow, lymphoid organs. So the lymphoid organs will be producing those leukocytes that are of lymphoid nature, which are lymphocytes. So produced in bone marrow, and guess what? It's red bone marrow, and also lymphoid organs. Now, leukocytes are interesting. They have a process where they will respond to their environment. And things that they will respond to will cause them to actually follow a certain chemical trail that's left behind. So chemotaxis here is the ability of our white blood cells to actually smell, so to speak, and I say smell because they're responding to a chemical scent. And the reason I say scent, material that's in an environment. And they respond to this chemical scent by noticing it, and then they follow it. So that's chemotaxis. There's this chemical in the environment. They notice it and they follow it. They're attracted to it. If we find them, typically our white blood cells are in the blood. And so they have to basically get into the soft tissues, which is where most of our infection is, correct? Most infections aren't sepsis, or bacteremia, just all the blood in the bloodstream. It's typically in a specific area. So white blood cells have the ability to smell a chemical scent and follow it, but in order to get there, they have to get out of the bloodstream, and they do this process called margination, which is lining up on the blood vessel wall, close to the area where this chemical scent is. And then as they are lining up on the inside of the blood vessel wall, they have to get to the other side of the blood vessel wall, and they literally have the ability to actually do one of those cartoon actions where you see something that's big suddenly squeak on down to a very little thing and then squeeze on through and then get out on the other side. And that's called diapedesis. So squeezing through that capillary wall to the other side and into the tissues. And once in the tissues, they act like amoeba. So when you have amoeboid movement, you're not in the bloodstream because the blood's carrying you. But now you're in solid structures, soft tissues, and you have to move there, and you do that by amoeboid movement. I don't know if this will come on up. Let's see if it will. Updates.
Neutrophils are by far the most abundant type of white blood cell at 60% of our overall count. These cells are usually the first to the scene of bacterial or fungal infections. This neutrophil is chasing foreign bacteria. Eventually, it catches the bacteria and is engulfed into the neutrophil cell membrane. Neutrophils are incapable of renewing their lysosomes, so after digesting just a few of these, they will die. Neutrophils, along with other cells, find their way around by a process called chemotaxis. Following a specific chemical signal, these neutrophils are guided to the site of inflammation within minutes. Leaving the bloodstream, they migrate into the endothelial cells to reach their point of destination. Once they have arrived, they will begin phagocytosing any bacteria present. Neutrophils suffer high casualties, and the result of this is visible in pus seen around the site of a wound.
YouTube's a great site, isn't it? Okay, so that's showing you a little bit of that margination. Didn't show it for very long, but then the diapedesis, where they move through the blood vessel wall, and then they have obviously a very obvious amoeboid movement once they're actually in the soft tissues. Let's take a look at the various types of white blood cells or leukocytes that we have, and there's only 5 different types. We put them in 2 major categories. You are either a granulocyte, which means we can see granules in your cytoplasm with our light microscopes, or you are an agranulocyte. Now, that doesn't mean that there aren't granules in agranulocytes. It's just that we could not see them when we first identified them and started talking about them with our typical light compound microscopes. So granulocytes mean it's easy to see granules in the cytoplasm. The number 1 granulocyte that we actually have, which was that little YouTube story about, are neutrophils. They are the most numerous of our WBCs. They are a minimum 50%. And YouTube said 60 and the book says 60, but I just like to, I'm sticking with old numbers, 50+%. When you take a look at them, we'll see faint granules in their cytoplasm. The nucleus will have 3 to 6 lobes, and so they're considered multilobular nucleus. They indeed are phagocytes that are associated with acute bacterial infections. It also mentioned fungal infections, but let's stick with bacterial for right now. And the granules that they do have inside them contain various enzymes. And enzymes with as well as antibiotic-like proteins that we call defensins. So the antibiotic-like things are referred to as defensins, which we're going to let you know that these guys are designed to poke holes in a cell membrane. So bacteria have cell membranes, cell walls and cell membranes, and they poke holes in them. Once you poke a hole in something, what happens to its insides? They explode out, and also when you poke a hole inside of them, water can flood in and also cause them to explode. The enzymes that they have inside them help to form peroxides that are also very effective in killing bacteria. So that's our neutrophils, big time killers for us. As noted, once they are not the ones that live to fight another day. They come in and they fight the infection by engulfing them, and then their lysosomes fuse with the vacuole that they brought in and kill off the organism inside that little vacuole, and then after a while they actually then die themselves and are indeed the pus that you actually see at an infection. Eosinophils are anywhere from 1 to 4% of our WBC count. They're called eosinophils because they like red stains. And so the red stains are actually confined to the granules inside them. And so the granules appear very dark red. The nucleus itself has 2 lobes. The granules, these enzymes that they carry, actually are designed to kill parasitic worms. So they'll find a parasitic worm in your system, and then they'll dump their enzymes on that parasitic worm. They don't engulf the worm. They actually exocytose those enzymes, and that's what actually, it's like pouring acid on them. It ends up killing them. The problem with eosinophils is that when they actually dump their granules, it also creates damage to tissues around them. So they contribute to tissue damage and inflammation. There are some people that have too many eosinophils for their own good. And these people usually have asthma or allergies, or both, and or. So it's not uncommon to find somebody who's having poorly controlled asthma or poorly controlled allergies to actually have a higher than normal eosinophil count. Basophils are really small. Look at that. 0.5% of all of our white blood cells are basophils. They indeed are the least numerous. The granules take up a basic stain, and so they appear blue-black. And inside these granules are histamine and heparin. You recognize any of those 2 words? So histamine, what does histamine do to you? That's something that we experience when we're having like allergic reaction, right? A big histamine release. And histamine causes increased vascular permeability or leakiness of our blood vessels. And what about heparin? Heparin's also a blood thinner, correct? And that will also further enhance leakiness of our vessels and causing things to leave our vessels. And when things leave our vessels, it's typically fluid, right? Because we said red blood cells stay inside the bloodstream. So the fluid leaks out into the tissues, and the tissues get very swollen or edematous, right? So that's what histamine and heparin will do. The nucleus in these guys in basophils are typically U-shaped, but it's so hard to see the nucleus often because they are so full of these basophilic staining granules. Indeed, histamine is a potent vasodilator, increasing the blood vessel diameter, and is going to definitely increase our inflammatory response. So what they do when you have your vessels are increased leakiness, we can get the fighters also of infection to an area within that fluid. Those are the granulocytes. The agranulocytes are called that because no obvious granules in them with our compound light microscope. Only 2 of those, because we already covered 3 of the 5, and the most numerous of our agranulocytes are our lymphocytes. They're approximately 25% of the WBC count. And lymphocytes are 2 major categories. You're either a B lymphocyte or you're a T lymphocyte. And so we call those B cells or T cells. So when you hear the word B cell or you hear the word T cell, realize we are talking about a lymphocyte. It's a more specific lymphocyte, but it's still a lymphocyte we're talking about. When you take a look, because we're going to look at the pictures down below of a lymphocyte, you will notice that it is about the same size, a little bit larger than a red blood cell. All the others are indeed much larger than a lymphocyte. Monocytes are about 5% of our WBC count of a normal person that's not having any problems. And if we find them in the tissues, they're doing their job, they're being macrophages. So when a monocyte leaves the bloodstream and is now in the tissue, it is a macrophage. Let's take a look at some of these pictures here and see if you agree with me. Okay, the biggest cell is the monocyte. So take a look at this guy and take a look at these surrounding red blood cells. He is at least, well actually look at here. Here's a red blood cell and here's another red blood cell. He's more than twice the diameter of 2 red blood cells, correct? So that's why I say you can use a red blood cell as kind of a measuring stick. So the monocyte's the biggest of our cells, and it has a pretty big nucleus, and it has obvious cytoplasm to me when I take a look at it. Let's take a look now at the lymphocyte. Well, the lymphocyte over here, he's definitely bigger than a red blood cell, but definitely not the size of a monocyte, correct? Much smaller than that monocyte is. And he is almost all nucleus with just a sliver of cytoplasm around him. A lymphocyte is commonly mistaken for, a lot of people want to call a lymphocyte a basophil. Do you see why they want to do that? But look at the size, people. Look at the size of a lymphocyte and look at the size of the basophil. The basophil is at least 2 red blood cells in diameter, whereas the lymphocyte is not. And so it's easy to confuse a basophil with a lymphocyte if you if you only look at the coloration, because those dark granules are obscuring the nucleus, correct? But definitely size makes a major difference, so keep that in mind. And a basophil has how common in a normal WBC count? It's the least numerous. So if you find something and you say, I can't tell if it's a basophil or a lymphocyte, what should you say it is? A lymphocyte, because you're going to be right at least 95% of the time. Eosinophil, look at those granules in the eosinophil and that bilobed nucleus that we actually see there. So eosinophils are pretty big cells. They have some really prominent red staining granules. I think that they're kind of easy to identify. Some people have, at first, they want to give a neutrophil more color than what they see in it. A neutrophil doesn't have anywhere near as much red stain to their granules. It's more pinkish. Eosinophils really have that really more reddish stain to their granules. Neutrophils will have a pinkish stain. The other thing, too, about neutrophils, look at the nucleus of this neutrophil and compare it even to the nucleus of the eosinophil. The neutrophil nucleus will have anywhere from 3 to 6 lobes to it. And what I mean by that is it'll be you'll find that it just has all kinds of fragments. It doesn't look kind of like fragments to you guys of a nucleus? It will have all kinds of fragments to its nucleus. And that is much more common in actually a neutrophil. Let's move on to now platelets. So we talked about red blood cells, we talked about white blood cells, and now we're on to the little bits, the thrombocytes. Thrombo makes you think of what? Have you ever heard of another thrombo thing? Thrombus. Have you ever heard of the word thrombus? Ah. So thrombocytes are another name for platelets. Because guess what? They are involved in the formation of a thrombus as well as blood clotting. So platelets, abbreviated PLT, commonly in the hospital as well as here, is it's just a bit. It's a piece of a big cell that was originally called a megakaryocyte. So this was a giant cell. And this is also in your marrow, in your red bone marrow. And so these big cells ended up literally losing buds of cytoplasm. And that's what a platelet is. A platelet has no nucleus in it, but it has the cytoplasm that the megakaryocyte had. So it has actually some little granules in it, and we'll talk about what those granules are in a moment. Platelets are really important. They are fragments, and here is a scanning electron micrograph showing you an actual blood clot. What is the most predominant cell in this blood clot? Take a look at the background, and what do you think the most predominant cell is in a blood clot? It is a red blood cell. And what do clots look like? They're red. Absolutely, they're red. And that's because the red blood cells get trapped in this clot. Okay. And they have no choice because they're the predominant cell in blood, yes? And clotting is a feature of blood. So our platelets here, these little guys all over the place, are attached to these threads. These threads that we see are called fibrin. And this is an insoluble protein that was in the bloodstream in a soluble form, which means dissolved. And because of an enzymatic reaction, which we're going to go through, became insoluble and started to create this network, this meshwork around the wound. So this is all around the wound. The platelets are stuck to the wound. They're also stuck to these threads, and these threads act like sutures. And the platelets act like surgeons. Because what do surgeons do with sutures? They put them in a wound and they tighten them up. So we're going to talk about that now. So hemostasis, the stoppage of blood flow. There are 3 phases to hemostasis. The first phase is vascular spasm. The second phase is the formation of the platelet plug. And the third phase is coagulation. All of these phases act just like you. You're in the kitchen and you're cutting carrots and you almost chop the tip of your finger off. What's the first thing you do? You pull your hand back and I hope you grab it. And you, what, do you just grab it lightly? You squeeze it, right? So just like what you would do if you cut yourself, you have the very same thing happening at the molecular or cellular level on you. You have vascular spasm, right? You want to squeeze that pulsing blood vessel. You don't want it squirting your blood out in your environment. So you reach over, you grab it, and you squeeze it to make it stop. Vascular spasm, constriction of the blood vessel. This will reduce your blood loss for about 30 minutes. And indeed, this is a neuronal or neurological event to the injury or damage. But it fatigues. So after 30 minutes, it won't be very good for you anymore. And obviously, the larger the vessel, the less effective your vascular spasm is going to be at actually squeezing off the big hole. We can squeeze off little holes better than we can big holes, right? Somebody cuts off their arm, you're not going to have enough vascular spasm to stop squirt, squirt, squirt. You're going to have to do your own tourniquet, right? Okay, so that's tourniquet on the man-made basis, hemostasis. Then, okay, you cut your finger, you grabbed it. What's the next thing you're going to do? You grab something to put around it, right? Some sort of rag, paper towel, something along that line. Formation of the platelet plug. We're going to actually stuff something into it trying to actually stop that. So with the formation of the platelet plug, this is designed to be a temporary seal. Of the break with a bunch of platelets. This is designed to give you more time. So when you cut across a blood vessel, you have cells on the lining of any blood vessel that are called endothelial cells. So endothelial cells are in all of your blood vessels, whether you're an artery, capillary, or vein. Every single cell on the inside is called an endothelial cell. What's important is when they're healthy, they actually release chemicals that prevents platelets from sticking to them. So they're always secreting their, I feel good, leave me alone, little surface medications, so to speak. And in doing so, this will keep the platelets from wanting to have anything to do with them, and they'll just float around in the bloodstream until they find an area that isn't healthy anymore. And when you are cut across, what's important is You are then damaged. Damaged cells can't release this. Plus, it's not just the damaged cells that's part of the problem. You went into the soft tissue, and do you remember what some of the stuff in soft tissue is all about? It's called nice strands that make up our soft tissue. Yeah, connective tissue, right? What's the major thing in our connective tissue? Do you guys remember? Fibers. And the most prominent fiber in our connective tissue is collagen. So damaged cells can't release this chemical that says, leave me alone anymore. Plus, we have collagen exposed from the underlying connective tissue. And this all says to the platelets, stop here and stick to me. So PLT with an S, platelets, is the abbreviation. So they stick to that collagen and they stick to those damaged cells like glue. And interestingly, now that they're stuck there, they're activated and they release three major chemicals. They release serotonin, they release thromboxane A2, and they release ADP. We've heard of serotonin before, correct? In which system? The nervous system. Because serotonin is a neurotransmitter, is it not? Yeah, it's really interesting. So they're releasing serotonin, thromboxane A2, and ADP to the surrounding environment outside of them. And serotonin and thromboxane A2 does two things, whereas ADP only does one thing. Serotonin and thromboxane A2 enhances the vascular spasm. So in other words, extends the time of the vascular spasm chemically, because the neuronal thing actually will fatigue. And promote more platelet aggregation. So what does platelet aggregation, that word, mean to you guys? They're collecting, right? More platelets. So we're then releasing more serotonin, more thromboxane A2, and also ADP. ADP is kind of like a platelet aggregator. It causes additional platelets to stick. So ADP doesn't enhance vascular spasm. It's serotonin and thromboxane A2 that does. So they all promote, come on guys, let's all get together around this big gaping wound. Let's fill it up. So it's a temporary seal. Then the next part happens with hemostasis. This is the final event, and it has three subdivisions that we want to actually include in this process. We'll get to that in just a moment, because a liquid blood will turn into actually the clot, which is like jello or gel. Because when you see a clot, isn't that what it looks like? A fresh one? It looks like bloody jello. Now you'll look at it totally differently from now on. So before we get into the three events for a blood clot, let's talk about some terms here. Procoagulants, anticoagulants, thrombus, embolus, and hemophilia. Pro means for coagulation. And our clotting factors are synthesized by the liver. So clotting factors are in your plasma. Clotting factors are proteins in your plasma. So those are called plasma proteins. And they're circulating around in what, an active or inactive form under ordinary circumstances? Inactive form, correct. So procoagulants, clotting factors synthesized by the liver in their inactive form. Okay. And they're plasma proteins. Anticoagulant, of course, means against coagulation. And what's important is we have natural anticoagulants circulating in our bloodstream all the time. And that's to prevent any procoagulant from accidentally starting coagulation. So anticoagulants, more of this naturally occurring circulating in our bloodstream than procoagulants. That's a good idea. Let's make sure we have more anticoagulants circulating around in our bloodstream than our procoagulants. However, when you hear anticoagulant, you didn't realize this, but you have these anticoagulants, naturally occurring anticoagulants circulating around in your bloodstream. You didn't realize that because you associate certain medications with anticoagulants, correct? What's a medication that you associate with anticoagulant? What? Warfarin, which is Coumadin. Coumadin is given to people and they call it a blood thinner, correct? Okay. What's another medication that's commonly? Aspirin. Aspirin's abbreviation is ASA, by the way. What about heparin? Heparin is also given as a blood thinner. It's to prevent coagulation, correct? It's to prevent clots. So we give Coumadin and heparin to prevent clots, and the same thing with aspirin. Well, they work on different mechanisms, but I will tell you what aspirin works on. Aspirin works on platelets. So that's how aspirin is an anticoagulant. It interferes with proper platelet functioning. So it interferes with our second step of hemostasis. So aspirin is very effective on that because most people who have problems with where they're concerned about heart attacks, they take an aspirin a day. Is it a regular strength aspirin? It's a baby aspirin. So 81 milligrams of aspirin a day is a very effective way to actually prevent accidental clotting, because remember, our platelet plug is part of this coagulation process or hemostasis, correct? Thrombus. A thrombus is a clot that develops and remains in an unbroken vessel. So part of a clot that develops and remains in an unbroken vessel. So a thrombus actually starts on a vessel wall and gets bigger and bigger and bigger, correct? It actually can get so big that it can completely block that blood vessel. And if it's on your heart, that's called a heart attack, right? So a thrombus doesn't always have to block the vessel, but it starts to narrow it, correct? Because you hear about people getting thrombectomies and you hear about the carotid endarterectomies, blood vessels to their head. They're actually taking out a big old thrombus that calcifies. The longer it stays in there, the more calcified it gets. So if it gets calcified, if they can see it on a plain x-ray, which means it's calcified, then that thrombus has been there a long time. An embolus. An embolus is floating around in your bloodstream and it originated from a thrombus. So an embolus is a portion of a thrombus that broke off and now is floating in your bloodstream. Are thrombi and emboli, are they only in arteries, only in veins, or can they be in both? They can be in both, absolutely. They can be in an artery and they can be in a vein. So they can originate a thrombus or an embolus, can be either in an artery or a vein. Which one is immediately more bad for you? In the artery, because then means that it's actually stopping blood flow to that organ downstream. Hemophilia is also referred to as a free bleeder, and that is because they have a genetic lack of a clotting factor or procoagulant. So clotting factors are also referred to as procoagulants. So these terms I think are all important in understanding pathologies that happen with our blood and clotting mechanisms. So now let's go into the formation of the clot. And remember, there's 3 distinct steps that are going to have to happen, and that's what we have here in the coagulation cascade. Okay, a clot is usually completed within 3 to 6 minutes after blood vessel damage. And that's pretty much okay, right? Because remember, we can have vascular spasm for up to 30 minutes, and then we can also have the platelet plug form, which actually extends the protection time from getting a little leaky and not having enough clotting factors there to help you form that clot itself. So this is actually pretty good. 3 to 6 minutes after the blood vessel damage occurs, you actually already have your clot in there. And it does so because there's this process of an enzyme cascade where we will create one substance which will then cause the formation of another substance which will in turn cause the formation of another substance. So it's just cascading events. One turns on this, which turns on this, which turns on this, which turns on this. And that's why it's called the coagulation cascade, because that's the ultimate outcome, is to actually form that clot. And these are the 3 steps. Let me tell you, there are plenty more than this. These are the 3 steps I want you to learn about. There's actually more than a dozen. And these are the 3 main steps that are important to the formation of a clot. The first, which takes the longest time to do, is the formation of an enzyme called prothrombin activator. Let's take a look at the procoagulants that we need to actually create prothrombin activator. Because can't you see prothrombus activator? We want to create this blockage, which isn't that what a thrombus is too? Kind of, it's a blockage. So prothrombin activator. We need factor 10 plus factor 2 plus factor 5 plus platelet factor (3) plus calcium. All have to come together in your bloodstream in this area and work together to then create prothrombin activator. Which we are going to abbreviate PA. This is the slowest step. And even though it's the slowest step, 3 to 6 minutes, we have our clot formed. But this factor 10, factor 2, factor 5. You know how I remember all these factors? What's 2 times 5 equals 10. Plus calcium, and then you're going to have to add platelet factor 3, which is often abbreviated in other things as PF3. So now we have prothrombin activator, and it will actually convert prothrombin, which is the inactive, into thrombin, which is the active enzyme. So PA is responsible for this step. So now we have thrombin, which again sounds like thrombus, and it's going to be responsible for converting the inactive form, fibrinogen, into the active or insoluble form called fibrin. So now thrombin is the catalyst, right? Isn't that what we basically say? It's the catalyst. Same thing as is responsible as above. So thrombin is the catalyst for the formation of fibrin, which is insoluble in your blood. These fibrin threads will trap red blood cells and platelets and create that clot. So now we have that big glob of clot inside your blood vessel that was previously compromised, and do we want it to stay there? No, because in essence, it can actually ultimately obstruct the entire vessel itself if we don't actually do something with it and get rid of it. Just like if you have a scab on your skin, the scab dries up, so to speak, gets smaller and smaller, and the skin edges come together. And so we need that same process internally, and we also need to get rid of the scab, or the clot, obviously, on the inside to where it doesn't float off and become an embolus, correct? So we don't want this clot to become a thrombus or an embolus, so we have a process for this, and that is what clot retraction and fibrinolysis, lysis is to cut, is actually all about. Clot retraction is where the clot shrinks. And in its shrinking, will actually bring the cut edges together. Don't forget this picture up here that I actually had for you. So now take a look at all of these threads in here and realize we're going to cinch them up. And when we cinch them up, because we're all attached filling up this little defect, we're going to bring the edges of the defect actually closer together in doing that. And that's part of the clot retraction process. Clot shrinks, bringing cut edges closer together. Platelets contain, in addition to our three chemicals above, they contain actin and myosin. We've seen that before, correct? It's in any muscle tissue. Actin and myosin is in muscle tissue. So those little bitty things act like teeny tiny little muscle cells. They're not really cells, they're too small of a fragments, but all together, when you have a whole bunch of them aggregating, we actually get a big chain reaction of that. So that actin and myosin, because remember, platelets are stuck to fibrin threads, and start pulling on them. Because of that actin and myosin, to bring sides or edges together. And when they do so, as they pull things together, they're going to actually squeeze out our plasma I'm going to put this in plasma in quotation marks because it isn't plasma anymore, because it is really serum. Serum is plasma minus clotting factors. Do you see we used up all those clotting factors in the formation of the clot? Because everything that's in there is activated and will be used up. And now, because it's all been used up in this very localized area, we start pulling on those fibrin threads, squeezing out, just like wringing a dish rag, squeezing out fluid. But this fluid isn't just plasma anymore, because plasma has all kinds of stuff in it. This is now called serum. So if you've always wondered what's the difference between plasma and serum, have you ever heard of plasma and serum? Serum is plasma minus clotting factors. So that's what we get. Vessels are actively healing during this process. And isn't that why you get stitches? Bring it together, give it time to finish its healing process, and then you can take the stitches out, and the edges are now knitted back together almost like it never happened before. So clot retraction is very, very important in bringing edges together and to allow, once they're together, just like our skin, once we have our skin close to one another, they fill in the defect, and then everything gets all cinched up nicely by the CT, fibroblasts and the CT and things along that line. Well, you still have your clot there, right? It got smaller, but it's still there. We got to get rid of the clot still. So clot retraction, it got smaller. It didn't mean it went away. Okay, edges got together, but we need to get rid of the clot, and getting rid of the clot is that process called fibrinolysis, to cut up this fibrous meshwork or network here. And so fibrinolysis occurs when the repair is almost done, because you don't want to get rid of remember, if you get rid of your sutures too soon, what happens? It splits open. So fibrinolysis has to occur when we're almost all healed up, because if it happened too soon, you'd end up with a rent or a tear again in the fabric here. And so with fibrinolysis, you have to realize healing tissues must be releasing something. They release an important chemical called tissue plasminogen activator. It has an abbreviation that is actually used in the medical community. Tissue plasminogen activator is also called TPA. Anybody working in healthcare ever heard of TPA before? Yeah, they use it all the time as a, quote, clot buster. So when somebody comes in with a heart attack, guess what they'll give them? TPA. Well, our healing tissues is where TPA came from. So TPA is a normal chemical released by healing tissues to bust up the last of that clot. The clot got smaller and smaller, but it's still there. And if we don't bust it up, we'll end up with, all these clots all through our bloodstream, and you won't be here for very long if you have all these desiccated clots inside your blood vessels. So TPA, tissue plasminogen activator, is released by your healing tissues. It starts a cascade of event. Starts an enzyme cascade itself, which results in the digestion or destruction of the clot. So that's all about hemostasis. An interesting and complicated process. Remember we said clot formation was one of the things of positive feedback, and that's what this enzyme cascade is all about. So clotting is a positive feedback mechanism. Until we actually get reapproximation of the tissue edges and healing tissues to release other chemicals to stop that process, this is what it's all about. Keeps you guys all here. You guys are here for many different reasons, not just to pass the class. Well, actually, you are here to just pass the class sometimes. Heart. Let's just talk about this for a little bit because this is what you're doing in lab. Heart anatomy. Heart's the size of your fist, located in an area called the mediastinum, which is in between your two lungs, your right lung and your left lung, and it's the inferior aspect of that space in the mediastinum. This is a cadaveric heart, which means it's a dead heart, and so living hearts don't look like this, but cartoon hearts don't look like this either. And so most of the books have cartoon hearts in them, and I actually prefer to use this cadaveric model because this is more like what you'll see in the lab as well as on any sort of test. The top one is the anterior view. The bottom one is the posterior view. I think they look very different. And so as you take a look at both the top one and the bottom one, make sure that you can see what makes them different to you. What I want you to appreciate, when somebody gets a chest x-ray, they look at the heart, don't they? You know, they look at the heart, make sure it's not too big, make sure nothing weird is coming off of it, as well as the lungs. So let's take a look at this and let's realize that the vessel that's in the front is not the aorta. The vessel in the front is the pulmonary trunk. So this is PT, pulmonary trunk, and it's in front of the aorta. And the aorta comes out from behind the pulmonary trunk. So this is our aorta. And the aorta is associated with which ventricle? The left ventricle. The pulmonary trunk is associated with the right ventricle. So right here is our RV. And right here in this area, in this sulcus, is some blood vessels that feed the heart. And we call the blood vessels that feed the heart coronaries, right? And they happen to be sitting on a sulcus that is an external representation of the interventricular septum on the inside. So then what's on the other side of that sulcus? This is the left ventricle. So when you do a chest x-ray of somebody and you're looking at the heart, what you have to realize, you're actually seeing more of the right side of the heart than you are the left side of the heart from this view, from this anterior to posterior view. Because over here is that right atrium. And there is a groove between the right atrium and the right ventricle. And you can call it an atrioventricular groove, can't you? And in that groove, you're going to find because we're on the right side of the heart, guess what we're going to find? A right coronary artery. And so that's a very simplistic way of starting to take a look at the structure. Everybody knows this is the apex of the heart, the pointy part. The base of the heart is more where it's on the back side. It's the back side. Take a look here. It says the left atrium forms the base of the heart. It's the back side and all of the blood vessels. So the base of the heart is the top of the heart, correct? And then we have our apex. So realize as you're working on your specimens that make sure you are looking at the front side and then the back side, and then make sure you keep your vessel orientation in proper view. We'll stop there and let you guys out.